And of course, we have a president to give us the next talk on Guide to Opening the FLACS Incision, Pearls and Pitfalls, Dr. Titiyal.
Yeah, good morning, friends. Indeed, a pleasure to be amongst the top surgeons of this country, and looking for devices that are going to help us in making our surgery more predictable, more precise, and with a better outcome. Just what we are talking about, doing a capsulotomy in wide cataracts. I think one of the first studies we done in a wide cataract only. We compared the femtosecond laser-assisted capsulotomy versus the manual capsulorhexis, and subsequently the incidence of a capsule giving way in these cases. And we realized femtosecond was equally as strong as the manual surgeries. The only difference we found was the circulatory index was better with the femtosecond created capsulotomies. And the incidence of radial tear was almost similar in both the categories. Though we did have a little bit of incomplete capsulotomy in femtosecond, but those could be managed very easily also, that we all know. Let me take you through the another important part, which many people don't like to use them nowadays, with the femtosecond being so popular, more number of cases. So I would just take you through how to make a perfect incision, how to open them, and what are the various ways to handle these also. So if you look into femtosecond laser devices, it gives you various options. So one is your main incision side port, which is routinely required for all your cases. Along with that, you can also correct the corneal astigmatism. So you can do arcuate incisions, you can do a limbal relaxing incision also. Though I would say today LRIs are not in that practice for most of us, but sometimes we still do arcuate keratotomy in these patients also. So if you look at manual incisions, though they have been perfect, but we have various devices, blades, diamond knife. They always give you a variable corrective effect. The size may be variable, the depth may be variable. Sometimes you are too superficial, sometimes you're too deep, sometimes rapid entry, and sometimes very, very unpredictable incision can be there also. Therefore, there will be why not to use a femtosecond laser device for creating these incisions? They require a good docking, then assessment of incision position and proper alignment are 2-3 important things also. So nowadays you have either a contact interface like you use for LensX devices, or you have liquid interface like in other systems. I use LensX, so I know how to do it in a proper manner. So good docking is critical, avoiding tilt, location has to be perfectly analyzed. Watch for other important issues like a very, very thick panels, pterygium, or deep-set eyes can be a major challenge in sometimes. So this is what we plan here. This is a temporal main incision, then your 2 side ports. So if needed, you can do arcuate keratotomies, and that can be nicely planned here. So there can be a little bit of energy setup difference, though you can have a same energy and spot separation for a main and arcuate and side incision also. So that can be planned very nicely. You can plan always, depending on how you place your second instrumentation, that can be 90 or 240 degree along the central areas of incision, and that gives you your own orientation of doing these incisions also. So safe, effective, I can consider because it can definitely decrease the corneal cylinder in your patients. Excellent, precise one. In fact, we did compare the 2 incisions, one made with a femtosecond laser, other with the manual blades. Disposable blades in these cases, looked for the configuration of incision in these cases and the DMD at the wound site in these cases. So we found there are 2 classical types of incision we create. One is a very smooth anterior or a proximal area of incision, and second is a ragged type. If you have a ragged incision creation, that has a much more chances of having a DMD at the area. You see this is a manual, you have a uniplanar incision most of the time, but if you have a femtosecond, so you can do a biplanar, triplanar incision making, which may be much more better in terms of opposition, much more in terms of better predictability in a post-op also. So these planning can be done by various formulas. You can use various nomograms to calculate these amount of arcuate keratotomy done in these patients. That will depend on the age of the patient, cylinder, with the rule, against the rule, or you can take into consider posterior corneal astigmatism also. So you can always go through the online calculator. But most importantly nowadays, people use modified Donald field nomogram for creating the arcuate incision also. So if you have an oblique astigmatism with the rule astigmatism, you can do a paired arcuate keratotomies. If you have against the rule, you can do a single arcuate keratotomy in these patients also. So this is one of indication. I think this is a patient where we'll be doing because this has a almost against the rule astigmatism, my arcuate keratotomy is coming here. That can be planned, and subsequently you can, when you create the fragmentation lens, then next will be incision. First arcuate, then main incision, then side port incision will come, which is effectively done in these cases also. LRIs are not really in practice, but sometimes you can do them when you have slightly larger incisions. It is always better to have toric IOLs as a replacement in these cases also. The challenge has been not only creation of the incision, its challenge has been to open them in a correct manner, easy manner, so that you don't disrupt the surface of the because most of them are clear corneal incisions. So this can be done by various methods. If you have an OCT attachment, that gives a nice way to look into. So mainly we are looking for silver reflection from the edge by drying with the mirror cell response. You see here, this is the main incision, little bubble here. We have a triplanar incision there. This silver lining gives the idea that this is the incision area. So first you have to open vertically, then go tangentially, horizontally towards the anterior chamber. This can be opened very, very easily. So if it is a clear corneal, the things are simpler. But if you have little limbal incision, the things can be difficult in some cases also. So this is a new technique which I use nowadays regularly. Put a little bit of trypan blue dye, which will enhance the incision area. It gives a very nice appearance of that area. Then dry this area and you can easily go through this. So this is one of the perfect incision you can see here, right near clear corneal incision. Dry that after putting a trypan blue dye, and you can simply open that with a spatula. First we'll do a little vertical opening here. Then just go horizontally, go inside, and you can see this will have a triplanar incision which has been opened here. The same thing for a side port also. And this incision, if you have a 2-incision side port, you can always manipulate your lenses, especially toric lenses. Manipulation, centration can be easier if you have a side port in both the side. You can manage with the right and left side ports to manage these cases also. And you can inject viscoelastic subsequently and take all the free floating implant. Put the lens and the surgery is over in these cases also. So this is what I was talking about, a smooth slit section like this, or you have a ragged one. The chances of DMD depends on the type of incision you create. So if you look into your incision regularly under the microscope, you realize which incision might give you more problems. So this is one patient with significant astigmatism around 1 diopter. I say significant because these are patients who are undergoing monofocal lenses, not toric, and you can manage this. If you have a cylinder which is more than 1, then toric lenses would be preferred in all otherwise also. So this is the arcuate incision we have created. I'll take you towards the end of my surgery. So once we complete the surgery, I'll implant the IOL. So under the viscoelastic retention, then go there with the spatula vertically down and open this incision. Idea here is to have the chamber should be formed with a viscoelastic so that you can manipulate this. This is a smaller incision. If I have a slightly larger incision, I use this separator, which is open like we used to do RK those days, and we used to have a wound separator, which will give you the depth of incision also. The depth is quite deep here, and the depth also gives you idea how effective this will be in a posterior period also. The other advantage of arcuate keratotomy, you can do intrastromal arcuate incisions also, and that can be opened next day also. I missed that video, it is not there. This is the same patient I took in a slit lamp, and I could open the arcuate keratotomy next day. So you can have, next day you can titrate after your surgery. Don't open the incision on the table the day you're operating. Next day, see what is your amount of cylinder with the patient. Then you can still titrate opening of these incision also. That can be done. I take around 1 diopter as a cutoff for doing a arcuate keratotomy in a femtosecond laser cases. And that might help you in sometimes in cases where they don't opt for a toric lens. So you can customize your incision, size, shape, depth-wise. As I said, they have a better stability of wound during the surgery and a post-op period also. chances of wound site DMD is less in these cases. Yes, there are difficult situations, deep set eye, uncooperative patients. Sometimes you have a large, arcus which may not give you a real good access to your laser being there, penetrating, and sometimes your incision may not be properly placed if you don't really look into the dimensions. One of the most important part when you are customizing your incision is to know white to white of your cases. That will determine how far back you have to shift your incision, and that will give you the perfect incision. Otherwise, you'll be always corneal, and that can be difficult. Sometimes it can be too posterior also. Thank you for your kind listening. I think if you understand these small things, your incision management will be better. But I would say this experience is based on a the LensX system where you have a contact interface. I think the planning of corneal incision are much better with these devices. Thank you again.
Thank you, sir. I think the point which conveyed is, I think, up to 0.75 diopters and 1 diopters you can correct. And I can tell you almost 50 to 60% of patients undergoing surgery, you can use LRIs very easily.
Yes.
You can access the LRI even a year later. As he said, next day to titrate, you can use the LRIs. So thank you. That was very important. And especially when you're using premium lenses, one, it saves you the cost. Up to 1 diopters, you don't really have to use a toric lens. The femto really works out. And also, you can correct astigmatism when you're using a multifocal. That is a bigger advantage to you. You can always go back and open up. The incisions are there for the rest of your life. The LRIs, so as much as you want it to work. Thank you so much. And again, a pleasure to have the president. First scientific session. I had the pleasure of sharing the dais with him. And congratulations to you, sir.
Thank you, Himanshu.
Thank you for your time.
I didn't realize this was my first assignment with you.
No, we had planned it that way, sir. We knew it, so.
Thank you.
Sir, but why don't you sit here now, sir? Ramu, come here now, please. On the stage. Yes, please, of course. So, we had the pleasure of having 2 presidents, one ex-president, Dr. Ramamurthy, and the present one. Look at that. How lucky can we get? 1 second, Mike. Ron.
Very recently I had a very difficult experience in the sense that I also used to believe that just about a 0.75 to 1 diopter will get corrected. Actually, astigmatic keratotomy in laser arcuate keratotomy was planned for a patient at 22 degrees at 60 degrees axis. Length of 22 degrees at 60 degrees axis. One of my younger surgeons had unfortunately had docked, and then she made a 60-degree incision, arcuate pad arcuates, at 22 degrees. And it's nearly now 4 months now. We have almost 3.5 diopters of astigmatism left over. And now actually I've ordered for a piggyback lens, and I'm going to, just going to be a custom-made piggyback lens, which I'm going to implant now. So even though we think that, I also believe that 0.75, 1 diopter is all that's possible. But this case, not even, I think it's almost 6 months. They have been difficult patient to handle. He received a trifocal lens. And now we are going to place a lens. And this correction which we achieved is quite stable over a period of time.
Yes.
It's of course anecdotal, but tells me that even such a large correction is possible. And second thing is that even most of our patients have against-dural astigmatism. And in all these patients also I use a pad arcuates. For the simple reason that, they are at 8 millimeters, and I make all my incisions with knife. Don't use the laser, and my incisions are anterior to that. So still I have the advantage of having an arcuate to deal with some amount of against-dural astigmatism, which all these patients have.
I think nice point, highlighted here. Normally, the incision which are towards the apex of cornea, as closer to the apex, you will have a more effect of these arcuate incisions. If you go posterior, the effect of same arc length is less. More towards the apex, you will have more incisions. That's why we normally keep it at 8 millimeter zone to create these incisions. And second important thing is what Dr. Ramamurthy was highlighting. If you have your very own, connected to the system, LensX, the entire thing gets transported into a lenses planning, and that also decreases the the torsional effect coming in your docking. So you will be always in the right place of your planning.
Dr. Himanshu, I wanted to ask you how is your experience with catalyst system? I know you have catalyst or
No, I have
okay,
the
Lensex,
Lensex.
okay.
I have the Alcon Lensex.
Okay, so because at times we have that chances in opening the main incision, so we have stopped doing.
We have the Catalyst, Lensex and Zima. All of them make...
And Ramu's hands, sorry. The last part was Dr. Ramamurthy's hands.
Yeah, and I use that most often, my hands.
But don't you feel that at times that they don't open?
No,
and
they
you get
don't
that-
open, sometimes you
Yeah.
feel as if the epithelium is getting scratched.
Yeah.
And I find though, OCT pictures show that very nice triplanar incisions and all. Frankly, we hardly have any difficulty with incisions which are made with a diamond knife and very precise.
Okay.
If you have the diamond knife, the new blade which you have been using, rather than I've seen people using a blade, they do like this, then do like this, and that's going to create a ragged incision. And that is a major cause of incision-related problems.
The good thing which is coming up in Catalyst is like they have the limited market release, which is there with Dr. Mahipal and everybody. So they have integrated IL master with the Catalyst. So cyclotorsion compensation is done like how it is done with the Callisto. So
I think it's Cassini which is integrated, not the IOL master.
IL master, sir. So the limited market release
Okay.
they have done. So it's gonna come in the market.
Okay.
In Lensar, you could Cassini, and you can have Pentacam and IL master also, which is a newer portable device coming up.
Thanks very much for the input. I think everybody can share. Do you think, Ramu, that was a lens tilt actually? 3.5 diopters of astigmatism, which you saw post-op. This is a rare surprise, rare that I have seen the lens really tilted.
No. We made a 60-degree pad incision. Instead of making 22 degrees at 60 degrees, the way it was she had opened up the incision also. So I thought it was just going to subside with time, so much effect will not be there. But it's just there.
So preoperatively, how much was the cylinder for that patient?
About a 0.75 or
Okay,
something.
okay.
So required a pad 22 degrees at 60 degrees axis. Instead, some misunderstanding, she made a pad 60-degree incision at 22 degrees.
I think we normally tell, corneal incision, there will be regression happening.
Yeah, I was
But in
hoping
this
for the
case, he was
regression.
hoping, but it didn't happen.
Very interesting, very interesting. It's just the corneal fibers which can misbehave the way they are put. What it shows is, even in LRI, you wonder how will it function. It may scar. But it's just the integrity of the fibers which are affected.